Welcome to the Vascular Testing Live Webinar Policies, Procedures, and Final Reports, What's Required and Why. My name is John, and I'll be your operator for today's call. All participants are in a listen-only mode throughout the webinar. This conference is being recorded. A short question and answer session will be conducted at the end of the presentation. I'll now turn the call over to Marge Hutchison, the IAC Director of Accreditation for Vascular Testing. Marge, you may begin.
Thank you. Good afternoon, everyone, and thank you for attending today's webinar. It's my pleasure to introduce to you Kathy Carter. Kathy has served as a member of the Society of Vascular Ultrasound Board of Directors, SVU Secretary, Annual Conference Program Chair, and is a Fellow of the Society of Vascular Ultrasound. Kathy is also a member of the SVU faculty for Vascular Interpretation course and is a member of the SVU Speakers Bureau. She has previously served as chair of the ARDMS Exam Development Task Force for the Vascular Technology Examination. Kathy is currently on the IAC Vascular Testing Board of Directors. She has authored and co-authored multiple articles in professional journals, as well as book chapters and other educational publications. And it is my pleasure to turn the meeting over to Kathy Carter. Thank you.
Actually, before Kathy begins, I'm going to do a couple of housekeeping rules for our webinar. Our phone lines, again, have been muted. Handouts of the presentation are available, and a copy can be requested via email to webinars@intersocietal.org. Help is also available at the same email address. If you are having phone issues, you may dial 0 on your phone for an operator to assist you. Again, this call is being recorded. And CME information, this is very important. Each attendee must be registered, log in, and attend the entire presentation and pass a brief post-presentation survey to be eligible to receive credit. Very important. If you are sitting with a group watching this presentation on one computer, all participants must have individually registered and individually logged in with their customized confirmation each attendee received via email. If you did not register or log in individually before you sat with your group, please make sure you do so before the presentation, or you will not be eligible to receive credit. How to ask a question. Please take note of the Q&A panel on the right-hand side of your screen. Feel free to submit your question at any time by simply typing your question into the box and clicking Send. Throughout the webinar and during Q&A, we plan to respond to as many of your questions as possible within the time allotted. Most likely, we will not have time to answer all of the questions, but if we don't answer your question, please don't hesitate to reach out to Kathy directly or a member of the vascular team here at IAC. Let's begin our presentation. Kathy?
Well, good afternoon to everyone. We're going to discuss today vascular laboratory policies, procedures, reporting, and some related subjects that may affect your accreditation application. First, there's some tools that can assist you in what might seem like an arduous task. We're going to talk about the scope of practice and clinical practice standards for the diagnostic ultrasound professional. These are important documents in our profession. We're also going to talk about professional guidelines both from the Society of Vascular Ultrasound as well as some of the guidelines that are contained within the application, the standards document on the IAC website, and those things that may help you in developing or refining your policies, procedures, and reporting techniques. So let's talk first about the scope of practice. I don't seem to be able to advance the slide.
Got it, Kathy?
No, it doesn't seem to want to advance the slide for me.
Okay.
Oh, I got it. Okay.
Perfect.
There we go. So we're going to talk first about the scope of practice. And this was a very important document published in 2000 that was participated in its development by the Society of Diagnostic Medical Sonographers, SVU, AIUM, American College of Radiology Representatives, American Society of Echocardiography, American Society of Radiology Technologists, the Canadian Societies, ARDMS, as well as IAC. It was to Ann Jones' credit that all of these people came together and were able to come to a consensus and define this document. The document is available in multiple places. You can find it on the SVU website if you click onto svu.net and go up to their Google box for search and just type in scope of practice. You will come up with this document, which is about 11 pages long, and it defines what we are and what we do and what our roles and duties are. And that's very helpful when trying to figure out how you're going to write down in a policy and procedure manual what it is that you do. It also contains clinical practice standards. And its purpose is to define for everyone what our role as members of the healthcare team really are, to act in the best interest of our patients. Of the myriad of things that are contained in this document, one of our duties is to provide a summary of findings to the physician of everything that we've collected in the data that we have collected in the course of our exam to aid in that patient's diagnosis and ultimately the management. Professional guidelines are contained within the general standards of the IAC vascular testing standards document. And this purpose is to refine and extend the performance levels that are expected in your clinical practice and better to reflect the day-to-day practice of vascular technology and what it should be. These represent the very minimal, essential elements of your performance. What do you have to do minimally to comply with the general standards and guidelines? There's another set of guidelines available to you that are available to anyone. You don't have to be a Society of Vascular Ultrasound member. They are on the website, open to anyone. These guidelines are specific to each area of testing, and they were written by experts in each content area. They are reviewed and updated regularly, usually every 3 years, and then approved by the Society for Vascular Ultrasound Board. And these can be used as an adjunct to the scope of practice and the clinical practice standards for the diagnostic ultrasound professional in helping you to develop your own set of policies and procedures based on those guidelines. Now, in all of those guidelines, there is an area that talks about presentation of the exam findings, to go back to what we talked about just a second ago. And in that section, it talks about providing preliminary results when necessary based on your own internal lab guidelines. We need to present a record of all the diagnostic images, the data you collected, any explanations, any omissions, any additions, and the technical worksheet to the person who's going to interpret this exam so that a diagnosis can be made and archived. We also have to have an ability to alert the vascular lab medical director or the appropriate healthcare provider if there's immediate medical attention indicated by the results of the study. And again, these are contained within those guidelines on the website you can see there. In addition to those two places, the American Registry of Diagnostic Medical Sonographers does a task survey for each specialty area that it does on a regular basis. And the one that was done in 2005 showed that 91% or almost 91% of people performing vascular testing gave preliminary reports. And therefore, at least since that time and probably much time before that, it has been an industry standard that vascular sonographers, vascular technologists give a preliminary report at the end of the exam, at least under circumstances and based on their own internal policy and procedures. So let's talk about protocols and procedures. While you must have standardized protocols for each and every procedure you perform in your facility, they also must be customized to your lab. So if you buy a set of a product out there, if you don't want to write your own of protocols and procedures, you have to amend those so that it matches what you actually do every day. It can't just be a recommendation coming from some person who's written a set of protocols and procedures. You can write your own. They're not that difficult. There's a lot of examples that are posted on the IAC website of policies and protocols and procedures that you can look at. They can be very simple, or they can be, much more complex. It has to do with whatever you want in your facility. But it does provide a more systematic, organized approach. It allows anyone who comes into your lab to know what you do and how you do it. So if you get a float person to come in, or someone that's a temp, they should be able to look at your policy and procedures and be able to say, oh, this is how they want me to do it. This is what I need to document, and this is the exact way that I want to do it so that I do it the same as everybody else. And this ensures a complete, comprehensive study without any omissions. So before we talk specifically about protocols, let's talk about policy, protocols, procedure. We have all these words. Policy addresses what's the rule. What is the rule that we have to follow? That's policy. It doesn't talk about how we implement the rule. Procedures are tied to the policies. Procedures help us make clear this relationship along with how the procedure helps to achieve the goals. Now, if we can link those things in everyone's mind that works in our facility, then that's helpful to ensure understanding and compliance. If we understand this is the rule of what we have to do and this is how we do it. And then a protocol, rather than a procedure, is the how-to part of the procedure. So let's talk about your protocols. The essential elements in your protocol, if you choose to write it yourself, should contain a purpose for each exam, an indication list, an appropriate indication list for that exam, contraindications, what equipment, what transducers are appropriate to that exam, what patient preparation may or may not be necessary for that particular exam. And then your protocol should be a recipe. It should be, how do I do this, so that I look at this and I know exactly what it is that I'm supposed to do, what data I'm supposed to collect, and what data I'm supposed to document. Then we should also include complications. What are the necessary minimum images or data that needs to be documented? What interpretation criteria are we using? And, of course, that should be internally validated. What reporting standards are we going to adhere to? What do we need to do in terms of reporting for that particular study? And then, of course, things like cleaning and care of the equipment, and usually people will include references so that you can sort of justify why you have said what you've said on how I do what I do. In addition, policies, not protocol, should include policies about how do I handle emergencies, what is my policy about equipment maintenance, how often, who does it. Almost every facility has to have a policy about how do you handle infection control and prevention of passing on anything to other patients. Patient rights and confidentiality is a big one in today's world. And then there should be a reporting policy. What do you do with unusual circumstances? What do you do if there's a change from the final versus the preliminary report? How do we report? And usually you need to include a safety policy as well. In addition to those policies or rules, there's usually a set of personnel policies that define how you determine competency of your readers and your examiners. How do you evaluate them, and how do you evaluate their work? If you provide training in your facility, then you need to have a policy that says what the rules are in regard to training. What are the rules in regard to orienting new personnel? What are the rules in regard to CME and how you collect that and obtain that and maintain it? There should be a policy that talks about regular meetings. Where do you have them? Who attends? How do you have them? How often? And, of course, you need a policy on quality assurance, and especially to be compliant with your IAC accreditation. So just to highlight some of the really important things I just went over very quickly, you need a policy regarding your preliminary reporting. You need a policy for reconciling what happens if there's a difference in that preliminary that goes to the referring physician and the final report that comes from the interpreting physician. You need policies for how you obtain your quality control and who participates. You need policies regarding cross-training if you provide that, and how do you maintain proficiency across those different areas. And then, of course, you need to make sure that your policies are going to meet the IAC accreditation standards. Something that's really important is if you did it, if you performed it, if you gathered the data, it needs to be documented and reported. It's not acceptable to say, well, it was normal, so I didn't take a picture. It's not acceptable to just say, well, I sort of saw something, but I didn't know what it was, and then that not be mentioned in the report. That is not acceptable. Standardized reporting forms will help eliminate some of those things. Technical worksheets are extremely helpful. The physicians that I used to work for loved them. It basically gives you a snapshot picture that summarizes the findings of all of the data that you have collected. Usually technical worksheets may or may not, but usually contain a brief sketch of the pathology that you may have found, and that's very helpful to that reader. Then they can look at that sketch, look at the summarized findings and data that you've collected, and then sort of helps them focus in on which images they really need to look at and pay more attention to than others. These technical worksheets may help you provide a more comprehensive study and lack omissions. Well, if you have a worksheet that has blanks that you need to fill in and you haven't filled those in at the end of the study and you see you have a blank, it's easier to remember that you didn't do that and go back and collect that additional piece of data. You must document all of the data that you collected, and all the data must be reported in the report. So let's talk just briefly about interpretation criteria. There's multiple criteria in the literature. It's been the source of many discussions. How do you choose what you're going to use in your facility? You need to use criteria that are developed for your type of equipment, your manufacturer, and that works for you in your facility. It's extremely important to adhere to that criteria that you have selected. Everyone in the facility has to use the same set of criteria, and it's equally important that you internally validate. Now, let's say for carotid studies, your medical director, your physicians have agreed they're going to use the Bluth criteria. And you find, as you go through and do your quality assurance, that perhaps you are overestimating or underestimating disease along the way. Those numbers then may need to be shifted slightly, and you can justify that because it needs to work for your patient population in your setting with your equipment so that you are as accurate as you possibly can be. That's the importance of internally validating and then adjusting criteria so that it makes you more accurate. If you have to read outside the selected criteria, you need to explain the reason for doing so. And one of the classic examples of this would be in a carotid exam. If you find that there is an elevated velocity across a section of the carotid artery, and yet there is not an amount of disease or no disease there to explain that velocity, and yet the patient has known contralateral occlusion, then you probably know that that increased velocity is compensatory flow for the contralateral occlusion. So you don't read that out as having a certain percentage of stenosis within that carotid. You say that the number falls within that set of criteria. However, this is probably falsely elevated due to compensatory flow for the contralateral occlusion, and that's sort of explaining why you're reading outside of the criteria. Quality control, a big area, a big problem for some people for some reason. There are lots of examples and guidelines on the IAC website that will help you with this. You must have internally validated criteria for each area of testing that you perform based on accepted standards. And all the interpreting and examining staff must adhere to that same set of criteria. It should be a team effort that everyone participates in the QA. It's not really a good idea if one person does all the QA because then the entire team doesn't learn. And the whole point of doing quality control is for everyone to learn from their mistakes, learn from someone else's perhaps wrong conclusion, and then you don't make that mistake again. Ongoing correlation of results can be done with multiple different gold standards, angiography, MRA, CT, phenography. But you also can use clinical outcomes. Sometimes you can use operative reports or even a second scan, as long as that's done within a defined period of time based on what exam we're talking about. So here's a couple of QA examples. There's a lot on the IAC website as well. This is one in which it's a simple matrix. And what we used to do was explain, especially if there was an outlier. And occasionally the physician would look at, say, a two-plane angiography and say, well, they didn't see what we saw, and this is the reason why. And we still correlate it to the gold standard. You can see here the number of studies that were attempted to be correlated is listed, the number of studies that had correlative material, the number of vessels with correlative material, the exact correlation. You're still going to say what that correlative number is, and no one expects everyone to have 100%. But at the same time, you can sometimes explain based on surgical outcome or based on other things that perhaps the gold standard you're comparing to was not the correct answer. Here's another one, just a simple matrix again for carotid exams. What you would do is put your selected categories of disease from the listing of criteria that you have selected in your lab, and then the same categories of disease based on whatever your gold standard is that you're comparing it to. Angiography, op report, most of the time it would be more angiography, CT, MR, something like that. In the case of arterial physiologic testing, most people would do two things. You would do a comparison QA for location as well as for severity and see how accurate you were for those two areas and then combine those results. Venous is a little bit different. There's fewer and fewer venograms done unless under specific circumstances the venograms are done. So in this case, most people would use clinical outcome or other things like that. It's relatively easy to get clinical outcome if down the road you contact the referring physician's office of a positive study and tell them that you are looking for correlation, and all they need to do is send you an office note that says the patient was treated with anticoagulation and got better. There's examples of that also in the logs on the IAC website. When you develop a quality control policy and procedure, you need to make sure it's meeting the IAC vascular testing requirements. The point of this is that it improves your performance over time and increases the quality of testing in the lab. That's sort of the whole point in doing something in quality control. And that's why it's important that everyone in the lab participate in this process and go over the results. This is so important that Medicare has recognized its importance and added time value to its calculations for payment. So even Medicare recognizes how important quality control can be in the accuracy and quality of vascular lab testing. So moving on now a little bit to reporting and interpretation. The purpose here is to translate the data that you've collected into a form that can be easily understood by the person who sent you that patient. So what are the reporting components? It's important to use a standardized format so that everyone reads sort of in the same way and the lab format goes out. You must have the date of the study, what was the indication or symptoms that prompted the study, what test did you do, a slight overview of the results. There should be the data there listed that the interpretation was based upon. If there were any limitations, that should be stated. And then a summary or impression of the data. Also, comparison to prior studies, if there were any, should be done. And then there must be a signature and electronic verification with date. There has to be a way of determining when this final report was signed and done and sent out to the referring physician. The report should also include who sent the patient to you for testing, who performed the test, and the facility and site where that test was performed. Reporting must include all the data. This includes measurements, images, recordings, and these must be reviewed by the interpreting physician. And our friends, the lawyers, would say not only must they review them to be paid for interpreting, but they also must have a mechanism to show that they did review all of the images and data. The report must be typed, that's an IAC rule, and accurately reflects the content and the data and the results of that examination that you performed. It also must be consistent with your selected diagnostic criteria you've chosen in your facility. So the requirements include review of the data and reporting of that data, the report contents, adherence to your selected diagnostic criteria, a measurement of the timeliness, and something in regard to preliminary reporting. So all reporting has to be standardized. All physicians need to agree on the same diagnostic criteria and the same report format. All right. In the report as well, reasons should be stated for a limited exam, comparisons with any prior study. Final impressions should indicate the clinical impression of the data. That means if the patient had a symptom or an indication that came in, what is the clinical relevance of the study data you collected as compared to those presenting symptoms? That's an important thing the interpreting physician needs to communicate to the ordering physician. All right, we're going to talk about standardized interpretation, but specifically adherence to the diagnostic criteria. If you've decided in your laboratory that you are going to use a set of validated criteria, can you say that there is a 75 to 80% stenosis, or can you say that there's greater than a 95% stenosis in a carotid? Only if you have a set of validated criteria for that small or discrete of a number. And most of us don't. And that's why most reporting and diagnostic criteria uses ranges that are somewhat wider. Here you see a 50 to 79. There are some people who want a greater than 70% benchmark so that they can compare to NASCET requirements. Whatever you've decided on in your facility, that's what you need to use. And the use of very small discrete numbers or something like greater than 95% is usually not something that you want to do. If you use terms like moderate or severe, those need to be defined, what that means. What is moderate disease? What is severe disease? In your criteria, that needs to be well defined. You also need to report on the extent of disease. If it's a venous study, it's very helpful to that referring physician if you're able to age the thrombus so that they know what to do with that patient if it's at all possible. Most importantly, at the end of the day, in the report, has the clinical question posed to you by the referring physician been answered? Did you answer his question as to, or his or her question as to what were they looking for? And that goes back to talking about, does the information you collected and the diagnosis you came up with match the presenting symptoms or indication that the patient presented with? Timeliness. In order to comply with IAC requirements, the report has to be completed, and there has to be documentation that that has been completed within 4 working days of the examination, unless, of course, you're waiting additional clinical information. If you need to bring the patient back and collect some more clinical information based on the physician interpreting saying, you know, I need a little bit more information, then it would be acceptable to delay until you obtain that additional information. If you do preliminary reporting, which as we see 90+% of us do, then their preliminary nature must be very clearly indicated to the person to whom you are giving that preliminary report, either in writing or verbally. A mechanism has to be in place for communicating significant changes of the report to the referring physicians. So if there's a significant change in the preliminary report to the final report, that should be communicated. If there's a significant change from the study done today, from the previous study done, that needs to be documented and communicated. And there has to be a way within the report that you have a policy in place to communicate any urgent or life-threatening findings in a very timely fashion. Now, Medicare is only going to pay if the services meet certain conditions for their fee schedule payment. Those conditions say that there has to be an identifiable, direct, and discrete diagnostic or therapeutic service provided to that patient, like an interpretation of diagnostic procedures. And that, this is the important part, the interpretation includes a separate written report. So each study that you do needs a separate written report. It's not usually acceptable for payment and not usually acceptable for IAC to have multiple studies on the same report form. Each one should have an individual report. Medicare additionally says that an interpretation report should address the findings, the relevant clinical issues, and comparative data when that's available. And it has to be a separate report from the office note. It can't just be the results sort of dashed off in an office note. And you can't limit it to this is a normal study or this is an abnormal study. It has to have more descriptors than that. So here is a complete arterial duplex report. That would include the indication, the body of the report, and a summary of the findings. This is not a complete arterial physiologic report. There's a summary here of the data that was found, but there's no interpretation of that data. So there needs to be a separate interpretation in addition to just spitting back the data. All right, what does this mean? What does grossly abnormal mean? What is the referring physician going to do with something that says grossly abnormal or significant arterial disease? Your diagnostic criteria need to be more specific than those kinds of terms. So this is not an appropriate report. What's missing in this report are the indications for the study. That's an important part of the report so that you can then decide whether your findings are consistent with the indications for the study or not. A complete carotid duplex report is going to contain the indication, it's going to contain the data, and it's also going to contain a final impression with a comparison to a previous study if there is one. Complete physiologic reports usually contain a bit about the severity as well as location. So there's usually a diagnosis in the impression that speaks to both severity as well as location in order for that to be a complete report. Complete visceral report, again, would contain the date, the patient's demographic information, the clinical indications for the test, the general findings of that test, and then the final impression of the test and how that falls into the clinical indications. So incidental findings, what do we do with those? Well, IAC says we must report them, but I would caution you to read within your scope. Your probe should be where your probe should be. So if you're doing an aortic exam, you really shouldn't be reporting an incidental finding of a pulmonary effusion. Your probe shouldn't be there, so don't go there. So in summary, review the reporting standards so that you know that you're compliant. Know that the physician must review all the raw data prior to making his interpretation. Your report should be standardized using the same format and the same diagnostic criteria across all readers in the facility. You need to consistently review your lab reports to make sure that they're compliant to these rules, and be critical of your own work. That's how you get better at what you do. So I think now we'll take some questions.
Yes, and thank you, Kathy. We are now moving to our Q&A section. I encourage you guys to join the discussion and submit your question at any time during the Q&A panel, using the Q&A panel, on the right side of your screen. So we're going to get started with the questions. I'm going to start with one question for you, Kathy, from Maria. It says, for final reports, So we need to have the date dictated, date transcribed, and signature date.
Marge may be able to help me with this, but here's what I would say to that, and that is at the end of the study when it's finalized, whenever it's finalized, that's the important date. Date dictated may be helpful for your own data in your own facility, but the bottom line is when was it completed, signed, and when was it sent out to the referring physician? That's what has to be compliant within that 4 days. Would you have anything else on that, Marge?
Sorry, I was muted there. Yes, that's accurate. Important to have the date of service, the date it was interpreted, and the date it went out, absolutely.
I hope that answers her question.
Yes, and this is actually a two or three-parter. She also wanted to know, is this mandatory and by whom?
Well, it's mandatory if you want to comply with the IAC rules.
I think it also is a Medicare requirement that the physician's signature be dated.
Okay, this is Linda. I have a question from James. What percentage of the procedures that have preliminary reports need to be compared to the final report? He gives an example. Let's say you have done 2,000 procedures with preliminary reports. Do you look at all or check a percentage of those?
Well, I would say that even though you're talking about 2,000, it's still very simple because the preliminary report should be a part of the data. It should be a part of the report. It's either on the technical sheet or it's somewhere as part of that exam data results. And if that doesn't match what the physician has read it as a final report, there ought to be a mechanism in place in your policy for how in your facility it's communicated to the proper person that these two did not match. It may be the technical director that has to handle that one. It may be that the reading physician has some way of communicating that to someone so that that is then looked into. Doesn't happen. It shouldn't happen that often, but if it does, some facilities would reach out to that referring physician and say, we know you got a phone call or we know you got a faxed preliminary report, and that's not what I think is going on here. Some physicians would do that. But I don't think you can say I'm only going to poll 10% of my 2,000 studies to see if my preliminary reports meet my final reports. It's just too important a piece of the study. Marge?
Okay.
Marge, have a response to that?
No, I concur.
Okay.
All right. I have a question from Gail. Can you use outcome studies for carotid and arterial studies?
Not sure how you would use outcome studies other than if you're using an operative report, which is somewhat of an outcome. If you don't have availability of angiography, CT, MR, those things, and you want to use the fact that the patient went to surgery, it's kind of imperative that you ask your surgeons to dictate into their surgical report something besides there was severe disease. Some physicians can make an estimate of the stenosis at the time of surgery. Some will actually use a sound to measure, and even though it's not a dynamic state when they have it open, but it's helpful if you have something besides just they went to surgery.
Joel's question is, how do you properly document that your diagnostic criteria have been internally validated?
Would you say that again?
Yes. How do you properly document that your diagnostic criteria have been internally validated?
Well, you're internally validated every time you do your Q&A. So when you do a matrix or when you do your log and you see what your accuracy is as compared to a particular diagnostic criteria that you have selected in your facility, then you're documenting what your accuracy is against that gold standard.
Okay, thanks, Kathy.
Okay. I have a question from Lisa. Says, is it still okay to use a matrix for QA, or is a log the preferred method for IAC?
Well, you can certainly use the matrix. That will help you determine your overall accuracy, but you are required to submit the patient log.
I actually have another question from Tanya. My physician is not on a PACS system, so what type of proof do we need to show our physicians look at all exams?
This question comes up a lot. I can tell you that the lawyers usually say that there has to be some mechanism. It can be a log they keep. They can initial the images if they're hard copy images. Whatever works for them that makes it easy for them to keep track of the fact that they looked at them.
Okay, this is Linda again. I just wanted to remind everyone that please be patient. We're trying to get your questions answered in the order that they're received. We have over 450 participants on this call, and we're getting lots and lots of great questions, and we'll keep taking questions and keep having Kathy and Marge answer them for as long as we can today. The next question is from Rose. Must the initials of the tech be on the images also?
On the images?
Yes.
The tech ID must be somewhere in the permanent record. It does not have to be on the final report. It does not have to be on the images. The standards are vague as to where you document it. It just has to be documented somewhere.
Okay.
Sometimes they are on the final report. Sometimes they are just on the tech sheet. Sometimes people, if you have a machine that when you log into the machine and you put the patient's name in, it automatically makes you tell who's doing that. So sometimes it's visible on the images. Sometimes it's not.
Okay. Thank you, ladies. I have a question from Jennifer. Should the final reports list all velocity measurements on a carotid examination?
The final reports should list all pertinent velocity information. If you took 6 velocity measurements in the mid-ICA, I don't think you need to list all of those on the final report, but the pertinent one of those 6. Sometimes I'll do a number of them trying to get the highest velocity if I feel like it's higher than I'm documenting. At that point, I would take the highest one to document it. But you need to, if your procedure, your protocol requires that you document proximal, mid, and distal ICA, then the final report should have proximal, mid, and distal ICA on it. I don't know that that's an IAC requirement, though.
It is an IAC requirement to document the pertinent positive and negative findings. So if it's not like in a chart or something on the final report, those numbers have to be dictated because somewhere you have to document those velocities.
Jackie has a question. She says she understands level, but is not clear on what extent means.
Well, for instance, if there is DVT in the limb, you really should, in the final interpretation and in the body of the report, say the extent of that DVT. I don't think it's appropriate just to say that there's DVT in the leg or in the, it should say what the extent of the disease is. Usually in an arterial report, you would talk about whether or not the disease was very focal or diffuse. that kind of information, talking about extent of disease as to how much real estate it's comprising.
Okay.
I have a question from Savina. It says, should you use several different gold standards or stick with one type?
Well, I think that depends on what you do and what the quality of your gold standard is in your facility. There are places where MRI is absolutely the best thing since, better than, almost than angiography or something, and people have just this high-quality MRI and they use that. There are places where MRI is not all that accurate for blood flow and measurements of stenosis, and in those settings people tend not to use. I think it depends on your setting, what your physicians want to use as gold standard, and what you have availability to do. I'd use everything, whatever's available to you, because if you need to get a certain number of correlations, if you limit yourself to one gold standard, it's going to be harder to collect that number. And it's simple as this: just do a log for your log can say, I used CT on this patient, and I used MR on this patient, and I used angiography on this patient, and it just has to list what you used as your gold standard. And you can do a separate matrix for each one of those gold standards if you want to.
Okay, Jane has a question. She asks, is an acceptable incidental finding in a carotid duplex thyroid nodules, or would this be a wandering probe too?
Well, since your transducer is already over that, then that is an area where if you see something abnormal, you should report it. If you're not comfortable saying it's a nodule, if that's not your area of expertise, then you just say that there is, the thyroid should be homogeneous. So if it's not, then there's an area of heterogeneity within the thyroid. Or if you know it's a nodule, then, if your physician is qualified to read, for instance, if it's a radiologist, most vascular surgeons are not necessarily comfortable reading specifics about organs and things that aren't in their area of expertise. So how you read that out sort of is dependent on who's reading. But since that, your transducer is over the thyroid in the course of doing a carotid exam, that's not a wandering probe. You should report that.
Great. Thanks, Kathy. I have a question from Matthew. Would the timeline reports be different if the physician interprets and is seeing their own patient in their own office?
No. I understand the reason for that question. I worked with, for 14 years for a group that we did the study, and they immediately saw the physician afterwards. And so somebody knows the results. I understand the purpose for that, but in order to be compliant, it may be that other people need that report as well. You still need to meet that 4-day benchmark, which should not be difficult to do.
Okay, I have a couple more questions about the, let me just put it out there to you. Joe asks, is it mandatory to keep tech worksheets in the permanent record along with the final report sheet?
I guess that depends on whether or not the data is on the final report or not. That might be a lawyer question. Marge, do you have an answer for that?
My recommendation would be yes, because oftentimes there is information on that form that doesn't make it anywhere else. I don't think it is required by medical record specialists, but certainly it can give you additional information that you may need at a later date. I would certainly recommend keeping it, and you certainly must submit it for us to review when you submit your case studies.
I know in one of the hospitals that I worked, it was considered part of the permanent record, and medical records did require that it got scanned in. And
right. You may want to check with your hospital or your local state government or medical record specialist in your facility to see what they require.
Okay. I have a question from Claudia. You gave examples for arterial, carotid, and visceral. Do you have any report guidelines for venous?
Well, the report guidelines are going to be very similar. They're going to be, you need to have the date of service, the patient demographic information, the indication for the study, a section on the body of what you found. What did you do? I imaged the right limb from groin to foot, that kind of thing, and the veins in question. And then an impression at the end. And one of the things that I didn't say that maybe is important to mention is that in going to a lot of different places, there are some people who think that just saying at the end of the venous study that there is no DVT is a complete study. And in some cases, maybe that's true, but I'll give you an example of what I think is sort of a travesty in reporting, and that is I had a technologist that was a general technologist that I taught how to do vascular and stayed with me about a year and then went off to be a traveler. And in the course of her traveling, she was involved on the West Coast with this patient that she did a venous study on, and he had 5 venous studies. And because his symptoms persisted, the doctor kept sending him for more venous studies. He had significant swelling in a limb, and the minute she contacted me and said, the minute that I put my transducer down on that patient, I knew exactly what was going on, and no one had ever reported it, and that was the patient had an AV fistula in their leg. Well, she knew that from the hemodynamics, so no, he didn't have any DVT. Everything compressed, and everything was normal in terms of compression and augmentation and that sort of thing. However, the hemodynamics were grossly abnormal in the arterial and the venous system, and so she was able to answer the clinical question that physician had been trying to get at for a very long time, and all that he'd gotten up to that point was no DVT. So it's important to report everything that you find. Those were, significantly abnormal hemodynamic findings that were able to then answer the clinical question.
Okay, the next question is from Betsy. Who can a sonographer give a preliminary to?
I think that depends on the policies in place. For instance, I have called physician offices, and their policy is a nurse or a doctor has to take a report. So in that case, you can give it. I always get the person's name that I gave the report to, and I write down the date and the time that I gave them that report. If you fax it, it's helpful to know that it actually got there, especially if it's I'm not comfortable just faxing a report that has some pretty significant findings on it without checking to be sure that they actually have it in hand. Someone who can communicate that information fairly quickly, especially if it's, if you have your patient, even if it's a negative venous exam and your patient is sitting in the facility and can't leave until you get that answer to that referring physician, then that needs to be sort of communicated quickly, and I usually ask for the physician in that case. I hope that answered her question.
Mm-hmm. Joel's question is, can ABI reports be included in a lower extremity arterial duplex report?
Yes.
Not if you can, but not if you're going to charge for it separately.
Mm-hmm. If you do an ABI as part of your duplex exam, which is required, you either have to have that ABI interpreted on a separate report or included in that report, because technically the ABI is part of the duplex exam procedure. So either or, a separate report or included in the duplex report, but we see so often that people give all the duplex findings, and although the ABI is written on the report, nobody interprets it. So remember that requires interpretation as well.
Okay, thank you, Marge. And everyone, just to let you know, it is 1 o'clock. If we're going to go a little bit over and answer a couple more questions for you guys. If you have to drop off the call, we understand. Just make sure you do participate in the online survey that comes immediately following this webinar when you close out your window. So I'm going to keep going with a couple more questions for you guys. Is that okay?
Sure.
All right. I have a question from Randy. It says, how many cases are needed in a private practice setting, say for carotid duplexes for a tech?
Do you mean like for competency or that's kind of a vague question. I think if it's for competency, there is no number you can attach to it. It just depends on the quality of the exams that person presents.
Okay.
I'm just wondering. I'm wondering maybe if that person can be a little more specific. Were they talking about for accreditation or for competency or for?
Well, if you're talking about submitting an application for accreditation, you must submit 3 abnormal carotid case studies, and we would like them to be greater than 50% stenosis. You must represent as many technical staff and medical staff as possible without repeating them, as long as you have the correct numbers of staff versus cases.
Well, that's good information, even if that wasn't what he was asking, Marge.
I'm going to give you Belinda's question. If reading surgeons habitually do not review images and just read from worksheets, what do you recommend?
Well, sort of out of the scope of this this talk, but you might make them aware that that's considered fraudulent.
Because you're actually billing for that physician to have looked at those images.
Yeah, if that physician is billing for interpretation, that could be interpreted as fraudulent, and if someone wanted to whistleblow or whatever, that they could be at risk. The other thing is could he say, well, yes, I do look at the images? I don't know. That's why I said when you take this up to the level of the lawyers, they say that you need to have some mechanism in place to sort of prove that you did look at the raw data. That's sort of separate from an IAC question, though. That's not really relevant to accreditation.
Susan asks, does the date and time the study was actually done also need to be on the report? You may have referred to this earlier.
The date does. I don't think the time does.
Not the time.
Anna asks, if your lower arterial exam includes ABI and aorta, would you need 3 separate reports?
Well, your lower, go ahead. You want to go, Kathy?
No, go ahead. Go ahead, Marge.
I was going to say your lower extremity physiologic study does have to include an ABI, and that can all be one thing. If you also do aorta, my question would be, is it a complete aorta, or are you just looking at it? Generally, a complete aorta exam would require a separate report because it really is totally different from a physiologic lower extremity. And they are technically 2 separate studies.
As are duplex of the infrainguinal arterial system in the limb and the aorta-iliac system. So I'm kind of confused as to what she's asking. Is she asking about a physiologic plus aorta? Because those 2 are 2 different things and certainly should be on 2 different reports. if you get an order for a lower extremity arterial exam, I guess the question then is what is your policy and procedure in your facility as to how you answer that question? What do you do? Because normally you have to have a separate order to do an aortic exam.
Okay.
And know now, too, I'm not as facile as someone like Rita Shugart about all the billing issues, but, they're starting to do this whole thing about reducing reimbursement when you bundle things. So it really behooves you not to necessarily do those things at the same. If there's an appropriate indicator for doing the aorta-iliac segment, and there's an appropriate indicator for doing, lower extremity arterial, if you do those in the same date of service, you're not going to get reimbursed. So one of those is going to be reduced significantly, and so you might be better off doing them at two different settings anyway.
Okay, Lori has a question. She wants to clarify or confirm. Does the report have to be finalized within 4 days from the date of service?
Exactly.
It does?
It does.
Okay.
Okay, I have a question here from Amanda. It says, if you do have an incidental finding, how should you report it if it's not in the report?
Well, it should be in the report. If it's a true incidental finding, how you report that depends on the department you work in. If it's a radiologist reading it and it's within his scope of practice to read an incidental finding and he knows what it is, for instance, let's say you're doing a kidney study and you come upon a heterogeneous mass in the liver, then he could read that because he knows that's within his scope of practice to know, and he could read that and describe it and make a diagnosis as to what's in that liver mass. If it's a vascular surgeon and you're showing him a picture of a heterogeneous something in the liver, then he would most likely, since it's not in his scope of practice, he would most likely describe it as a heterogeneous collection within the liver that might need further testing to identify what's going on there. Any incidental finding that's significant should be in the final report.
Okay. Stephen has a question. We find that MRA of the carotid tends to overestimate the stenosis. Can we use this as a gold standard to compare our duplex results?
Well, that goes back to what I said earlier. MR is one of those things that is technically dependent, not unlike ultrasound, and it's very good in some centers and not as good in others. And there's different types of MR, different levels of MR. So you've got to use what you're going to be comfortable. If it is consistently wrong, based on if you have a third tiebreaker and it's consistently wrong, then you'd have to make a decision in your facility whether or not you're really going to use that consistently or not. It would be interesting to gather the data and to do a matrix and say, well, this is what MR is saying. And then if the patient goes on to have angiography or something done and you can sort of prove that it's over-reading it, you might not want to use that consistently as your gold standard. I hope that answered that question. It's a tough thing to do because all of these different imaging techniques have their ups and downsides, and the term gold standard is a little misleading.
Okay. Go ahead, Linda.
Suzanne is, it sounds like she's asking for more clarification, but it's with the preliminary report.
Okay.
Said, are we allowed 4 days before the MD finalizes the preliminary report?
Well, let me just clarify the standards. The standards say that the study must be interpreted within 2 business days, and the final report must be out the door, signed, sealed, and delivered within 4 days. So basically, you have 2 days, and it has to be interpreted either by voice, dictaphone, some type of some type of handwritten document. There has to be something that if somebody calls for that report, you can give them the interpretation, and that's a 48-hour policy.
All right, that speaks to the physician, so that you're talking about an interpretation by the physician.
Right.
I think she's probably asking about preliminary reports by the technologists that are sent over prior to the final report. And, I mean, the whole point of that is to get it out as soon as possible. Usually there's a policy in a facility that says, I'll call or fax or somehow manage to get a preliminary report to a physician under these circumstances. You know, newly diagnosed severe ICAD disease or new DVT or limb-threatening ischemia or, you know, those kinds of things that are life-threatening, limb-threatening. Those usually are communicated immediately to the physician in some manner, orally, you know, by the phone, handwritten on the progress notes in a hospital setting. And then, again, you've got to make sure that the final report is consistent with that preliminary report. I think, Marge, what you're talking about is once the physician looks at the data, before it's actually typed and stamped and date stamped and signed by the physician and goes out, that's available, you know, to somebody in some format to get what the physician said.
Right. The standard kind of gives you a 2-day grace period between interpretation and transcription.
Yeah. Well, that's what the other 2 days is for after.
Right.
So they've got to look at the data. The interpreting physician has to look at the data and do something with that in 2 days, and then there's 2 more days to get it transcribed and sent out.
Right.
All right, ladies, I have one more question for you from Maria. What is the requirement to comply with the electronic signature?
Marge, that's all you.
I'm not sure. I'm not quite sure what the question is, but electronic signature is very acceptable nowadays, both legally and medically. It also has to be dated. I guess I'm not real clear what that question is.
We have some other folks that were asking about, you know, do all signatures have to be handwritten on the final reports if they're using an EMR? You know, do they have to have a date and time stamp or, say, electronic signature on the bottom?
Yeah, electronic signature is perfectly acceptable, but it does have to be dated. And that's a very common practice is to date, and oftentimes it's timed as well. That's almost part and parcel to getting the electronic signature, but it will need to be dated at least.
Okay. Well, I thank you, ladies. This has been great. We had some great questions, but unfortunately we only have an hour, and we already went a little bit above that. So I'm going to go ahead and close this Q&A period. If we did not get to your question today, please do not hesitate to contact Kathy or the vascular team here at IAC. Again, I'd like to thank Kathy and Marge, and I'd especially like to thank everyone for joining us. If you would like a PDF copy of the presentation, please email webinars@intersocietal.org. One more important message. For those attendees that are participating in today's webinar for credit, once this webinar is complete, please make sure you close or click the red X at the top right of your window. When the window closes, you should immediately receive a window with a brief survey. Please complete the survey and submit. This helps us to confirm that you registered and attended the entire presentation. For those attendees that are viewing the presentation in a group setting, or for those that did not get the survey immediately following the presentation, you will receive a link via email to complete the survey. If you haven't received your credit by the end of the month, please contact me at webinars@intersocietal.org. Again, thank you so much for joining us, and I will turn it back to our speaker.
All right.
WebEx.
Well, thank you all very much.
Thank you, ladies and gentlemen. If your question was not answered during the presentation, please email or contact the IAC Vascular team directly. Thank you for participating. This concludes today's conference. You may now disconnect.
Thank you.
Thanks, Marge.
Thanks, Kathy.